Think forward. Think Research Channel.
Just recently, we tried to do a study on odontoid fractures, looking at a youthful population. When we looked at our case series, 4/5 of our odontoid fractures were above age 70. So without further ado, I'd like to introduce our partner, Dr. Chestnut, who has joined us, and he's talking about geriatric odontoid fractures. Thank you, Benny.
So I'm going to be talking about odontoid fractures in the geriatric population. Geriatric odontoid fractures are frequent in patients greater than 70, and certainly it's the most common spine fracture in patients greater than 80 years, which is not something we expect up front. 95% of these are type 2. Females happen more than males. They tend to fall forward. It gives them a generally posterior dislocated fracture. Now, the incidence of neurologic deficits is not age dependent, and fortunately it's also not high. But it's quite frequent to see these in the elderly population. There's also a high rate of complications, particularly in patients greater than 70 years. There's up to a 35% 3-month mortality, and complications are also high, ranging from misdiagnosis to complications due to associated injuries. But this is not an insignificant injury, and it's not only the fracture itself that seems to be involved in the complications, but it's also the secondary effects of the age and the treatment, sort of similar to the hip fracture patient. Now, we're all pretty familiar with the Anderson-Alonso classification. I'm not going to spend much time on it. Type 1 fractures, fractures just of the tip, are generally fairly easily treated, tend to heal and do well, low complication rate, no special age-related considerations. The same with type 3, certainly more extensive fracture, but a nice surface to heal. Pretty well treated, although maybe there's a shift from halo to cervical collar treatment there. And also, there's not much in the way of special age-related considerations. However, in the type 2 fracture, outside of the segmentally comminuted fracture, which is a slightly different variant of that and inherently quite unstable, there are treatment controversies. And there are age-related considerations. So the question is how does age affect the natural history of this disease, how to treat them both surgically and non-surgically. And the options range all the way from simple bracing. Classically, these people went into a halo. More recently, people have been treated more and more in collars, hopefully well-fit collars, not like this one. Surgery can be done posteriorly and anteriorly. Anteriorly, a very elegant surgery, a simple internal fixation of the fracture without crossing any motion segments. The problem with the anterior fixation, of course, is that it has been certainly rumored and certainly seen to have a high failure rate in these patients. So we've sort of been reticent to use what is, I think, our most elegant solution to this problem in a surgical fashion in these patients. So let's think about what promotes successful internal fixation of dense fractures. Clearly, bone quality is important, and as we age, this is an issue. It's poor by definition in the aged patient. Tends to be quite weak down here where we place the head of our screw, weak in the area of the fracture itself. It's actually quite strong generally up here where we capture the far cortex, but we have to be able to see the far cortex. So in the elderly patients, the problems with an internal fixation is poorer screw purchase and slower union. The same is that in order to get success, we need a complete reduction and a maintained reduction. Complete reduction generally has to do with how well we can hold it in place and how well we can reduce it. The maintenance is really the issue. In terms of an orthosis, halo has sort of been the gold standard. Certainly there are increased complications in the elderly. The issue about bracing has come up and has actually ended up as an argument for stable non-union as being acceptable. We'll discuss that a bit more. In terms of posterior fusion, which is the most straightforward surgical approach, it's quite a major procedure. It has been the one touted the most because the direct screw fixation has been thought to have a higher failure rate. So these are our options, none of which are as straightforward as we'd like to see. Finally, interdigitation of fracture fragments, very important on getting that reduction well done and held in order to get union. And certainly in the internal fixation, the direct internal fixation, these are critical aspects. If you don't lag the fracture down, if you don't interdigitate the fracture fragments, you will get failure of the screw no matter what the age group is. And finally, the capture of the far cortex is the #1 pulling force when you're lagging this down. Of course, that means that when you get older and lose bone quality, we have trouble both with getting this done because of poor bone, poor capturing of the far cortex, and poor apposition, and finally because difficult imaging. Some of these patients, you get them in the operating theater, you fire up the fluoro, you can't see the distal fragment. So there are a number of issues in the elderly. Now, is age really a problem? Well, generally the answer to that has always been yes. And there are a lot of studies that have shown age to be a problem. Nobody has done great multivariate control risk analysis. And so it's not really been done in a class 1 level, but certainly a lot of studies have suggested that there is an age-related problem here. On the other hand, other studies have looked at it and not found that. And it's never been clear why that is, because no one has ever done a study based on this where they've looked at bone density or other indicators of not just age, but bone quality. And that's probably the #1 problem in saying what the age cutoff is or what the age relationship is to internal fixation with a single anterior screw. So the age-related issues aren't as clear as we think. In general, it's gone all the way down to about 40 up into greater age groups, which really again suggests that it's bone quality. Is fusion necessary in elderly patients? It's been suggested in the report by Bob Hart et al., where they looked at intact patients with chronic dense non-unions and an average post-injury interval of 4.7 years, that none experienced progression of deficit. They all had good space available for the cord. Now, this was a retrospective sample of patients picked up at the chronic stage. They came back, they were seen to have non-unions and were doing well. And the problem here is that most of the patients who might have died didn't come back to clinic. And there are certainly issues where a number of case reports and case series of patients who have had late deterioration. So the problem with this study is not that we should accept non-unions up front. It's probably reasonable to accept a stable non-union when they come back sometime out from their injury and are doing well. But it's probably not up front to treat them in a way that has an increased likelihood of non-union. And that's the problem with this study, is that there's no denominator. He doesn't know how many patients were treated and how many patients might actually have failed. Does surgery influence the functional outcome of elderly patients? Well, the best study available on that had 57 patients in it, not all of whom were geriatric. Type 2 and type 3 fractures, mostly type 2. Well, 6 patients were treated with immediate posterior fixation, 47 patients were placed in a halo or a Philly collar. Asymptomatic non-unions seems a bit high, not inconsistent with other types of treatment in these patients. Pain scores were higher in halo patients, did not reach statistical significance, but it did seem to trend towards increased age. So the halo seemed to have higher pain scores than the surgery, somewhat surprisingly. Significantly higher rate of complications with halo use in the elderly. But in the long run, older patients treated surgically did not have better functional outcome scores. So it does seem that in the short run, in terms of complications and pain scores, that surgery was actually less of an impact on the patient than halo or collar fixation. In the long term, it didn't have functional outcome differences. And certainly we know the halo complications, which get worse in the elderly, both due to bone quality, due to the complications of immobilization and wearing the halo. And most of these patients don't end up going home. They go to a skilled nursing facility, sometimes decompensating in their ability subsequently to go home, even if they do heal. Now, how about the halo versus hard collar? That has also been looked at in a case of both type 2 and type 3. In terms of type 3 fracture, they did well. Collar or halo vest, fairly small number of patients. I don't know what to make of that, but we're not really concentrating on type 3. In terms of type 2 fractures, 20 halo vests, 16 collar, no significant difference between halo and collar in the need for later surgical intervention, stability and flexion extension after removal of the orthosis, or rate of fracture union, suggesting that the rigid cervical collars can serve as a substitute for halo in most patients. Now, most of these were well reduced and well aligned. This is not patients who are difficult to maintain in alignment. And finally, does age affect outcome from anterior surgical, anterior screw fixation? This is really important because this is a quite simple surgery, quite easily done. And a recent study suggested that probably the way we've been thinking may not be the way that it actually is. It was a retrospective study. It was a complete cohort. They didn't lose any patients. They didn't fail to capture any patients. And they eliminated unacceptably high anesthetic risk. So patients who were not surgical candidates didn't go to theater. There were two groups, patients greater than 70, patients less than 70. They all got screw fixation and wore a collar for 6 weeks. And you can see here that, that when we start to look at the division of the two groups, there was no alteration in fusion rate in the older group versus the younger group. And there were quite a number of older patients. Non-unions were fused posteriorly, but they were the same rate in both groups. There was also no change in neurologic outcome. Medical complications were higher in the elderly group, but these are also consistent with the number you saw before and the numbers you'll see in the posterior fusion. There was one surgical-related death which did not appear to be related directly to the surgery. And finally, is posterior C1-2 fusion so much better? Campanelli reported in 7 geriatric patients with displaced reduced type 2 fractures treated with transarticular screw, 11-month follow-up. Of the 6 patients with follow-up, 3 had solid union and 3 had fibrous union, which is not the greatest success rate. In terms of complications, they were fairly high. The literature complication rate ranges from 40 to 43%. They had 3 complications in their 6 patients with follow-up. So posterior surgery, which has always been our fallback, is very similar rate of complications and non-unions to other types of treatment. It doesn't seem to be inherently superior. So based on this, I think one way to look at odontoid fractures in the elderly patient, and now again, I'm saying elderly, it's probably an issue of bone quality, but given what we're talking about, we'll at least correlate it with age. I think what we've got to start with is, are they a high surgical risk? Because many of these patients are, and surgery is really not an option. If that is a yes, the question is, are they displaced greater than about half a centimeter? If that is true, they need reduction. If you have success, they probably should be held in the best device we have to maintain them in reduction at that level, which is still the halo. If not, we have to reconsider surgery balanced against the high surgical risk, or then we have to go ahead and leave them in a partially reduced state, hoping that they heal. If they are not displaced to that extent, we should try a rigid collar. Now, it used to be that would have said halo, end of story. But at this point, we should probably try a rigid collar, mobilize them, and leave them in a rigid collar unless they fail mobilization. A bit of a change in practice based on data. Therefore, halo use has really fallen back to some extent. Clearly here, where we need to hold a difficult reduction in place, but here it's going to be a smaller fraction of the patients than would have all gone into a halo before. In terms of the non-displaced union, if you are displaced and displaced significantly, we again need closed reduction. If we have success, then posterior fusion seems to be the treatment of choice. We could also try holding them in place with the halo. Again, the studies suggest that surgery in terms of the short-term impact on these patients is probably less hard than halo fixation. If not, then we will have to consider an open reduction, and that is more clear, the use of surgery. So the use of surgery has to be considered as a very viable option to patients who otherwise might be treated in a halo in a low surgical risk patient. Finally, if they have poor bone density and they are not displaced, we should consider posterior C1, C2 fusion, as we discussed before. On the other hand, anterior screw fixation is not ruled out in these patients. If they have reasonable bone density, good proximal cortex, and good distal cortex, you can see them in theater, capture the far cortex, and lag the fragment. No longer should we say that anterior screw fixation is not a choice in these. So it's going to be not just age, it's going to be our impression of reducibility, operative candidacy, and bone quality that will allow us to again consider probably the most elegant treatment, but one that's been not thought as being applicable in this group. So really now the question becomes poor bone density, which is really what should be the focus of any further studies. Thank you very much.
Thank you, Randy. The next speaker is Dr. Daly. He'll talk about the surgical options, some recent changes that have taken place.
Well, we're going to talk mostly here about the posterior options for C1-2 fixation. And obviously in the elderly, the C2 fractures and the C1-2 combination fractures are the primary indications for this. But of course, things like atlantoaxial instability in rheumatoid patients, tumors, even osteodontoidium that can present later in life are all indications primarily for posterior fixation as opposed to anterior fixation. Now, the anatomic considerations of the C1-2 region are quite unique. This is the only joint in the spine that really looks like this. And what it is you have the flat lateral mass of C1 and the flat lateral mass of C2 and no disc and annulus in between. So the usual techniques that we can use of anterior fixation and anterior interbody fusion are completely not applicable at all in this situation. Now, the unique anatomy allows for quite a bit of flexion and quite a bit of rotation. And really, this is where you get most of the rotation of your head. 60% of your rotation comes from the occiput C1 and C1, C2. There's also 40% of your flexion. So anytime you're talking about fusing these joints, you also have to counsel people that they're going to lose quite a bit of motion associated with the fusion. Now, traditionally, obviously, halo immobilization has been the technique to try to immobilize people as best you can in this region. But even halo only limits 70 to 95% of the motion. A hard collar sometimes can be quite good, but again, if it's not well fitting, you don't get very good limitation of motion. And even in the best situation, you're really only talking about 60 to 80% of your flexion and extension eliminated and 50 to 70% of your rotation. So immobilization with a collar or a brace is useful, but not completely effective. Here's a good example of loss of fixation. This is a gentleman, 66 years old, had a fairly innocuous fall, and I think you can see across the top here that he has an odontoid fracture right there. It looks in great alignment at this stage, and you think, well, this would be a perfect candidate for external immobilization. We went ahead and put him in a brace, and even though he's angulated here slightly posteriorly, still not bad apposition of the fragments. Unfortunately, just from going from supine to up in immediate films, you can see how much he's angulating and translating here. We played around with this guy. I think it was somebody I had the benefit of taking care with when I was Jens's fellow. We played around with him for 4 or 5 days and finally said, okay, enough of this. So halo is probably not as good as we think. Which brings us to really what are the traditional C1-2 fixation techniques. Well, obviously wiring has been around for a long time, and good wiring and bone fusion techniques are still very useful, particularly in somebody with soft bone. The traditional techniques are, as you see here, the Brooks fusion up here at the top, and then the galley fusions that you see down here at the bottom. Now, wire fixation in and of itself is not all the same. When you look biomechanically at these different fixation techniques, there are certainly techniques which are better. And in biomechanical studies, clearly a Brooks technique is significantly stiffer than a galley technique. The downside, as I had mentioned before, is that you have to pass sublaminar wires not only under C1, but also under C2, which theoretically increases the risks of complications, neurologic complications, from passing your sublaminar wires. The other problems with C1-2 fusion and wiring are they're just not as stiff sometimes as we would want. You still have a non-union rate of 10 to 30% when you use wiring, and you still need a rigid orthosis or a halo. What has become much more common are the transarticular screw techniques. This was initially described by Mogrel in 1986, and people have shown over the years that this can lead to an excellent fusion rate. There are many series in the literature with published fusion rates of greater than 95%. Using a bone graft, cable, and transarticular screws. And good studies, again out of Curtis Dickman and the lab in Barrow, show that you have great restriction of motion. You become very rigid when you have transarticular screws and a C1-2 cable graft. You can eliminate all the motion that you would have in a destabilized spine. So it's a very good fixation technique. Problem is, not everybody has the anatomic suitability for a transarticular screw. Anybody that's done this technique certainly knows that 20% of patients, anywhere between 18 and 23% in the literature, will have an anomalous or high-riding foramen transversarum with the vertebral artery in there. And as you can see here on this patient on the left side on the CT scan, you would not want to put a transarticular screw in this situation because any transarticular screw would have to come very close to that vertebral artery and risk injury of it. Paramore reviewed a series of patients from Volker Sontag's group and found that in 94 patients, 17 of them had at least one vertebral artery that was anomalous. In other words, you didn't have that 4 mm pars that you needed to pass the transarticular screw, and that 3 out of 94 patients had 2 vertebral arteries that were anomalous. So absolutely could you not pass either transarticular screw in those patients. Here you see an example on the left of somebody that has a tight pars. You can probably pass that if you're if you've done a lot of these and you have a lot of experience with this. But certainly, even somebody who's experienced, that situation there on the right, that's somebody you probably wouldn't want to pass a transarticular screw in. Again, this technique does offer significantly stronger fixation, and you do not require a supplemental halo after that. Therefore, patients like it a lot better. The complications, vertebral artery injury and stroke is the one that we fear more than anything. The other, you can still have a non-union, even in a small number of patients. Obviously, things like a dural tear anytime you're operating around the spine. Suboccipital neuralgia, C2 nerve root injuries. Anytime you're trying to find that medial surface of the pars and you're trying to mobilize that C2 nerve root, people say that you can get suboccipital neuralgia. Now, I like to think of this technique as a situation where we're trying to eliminate suboccipital neuralgia, but people have reported that you can flare up that C2 ganglion and cause suboccipital neuralgia. Obviously, you have the problems with any hardware or operative surgery, such as infection and screw breakout, anytime you use this technique. The other problem with this technique is you need to have a reduced spine. In this situation, this is somebody who has a chronic transverse atlantal ligament rupture. They do not reduce inflection and extension views. In order to get this reduced, okay, and try to fuse the patient, as you see here on the right, yes, and this is the same patient, we had to go in and do a transoral release of this pannus that was behind the arch of C1 in order to get him back in an anatomic alignment. So you can't do this technique if you don't have a good anatomic reduction. A lot of people will use stereotaxis to help, and people do notice that you can place screws better with stereotaxis. There are a number of series in the literature saying, well, the CTs look better after we place these with stereotaxis, but there's not really a clinical correlate to it. In other words, if you're comfortable using fluoro and you feel like you can get these in with fluoro, that's probably just as good as image guidance, and certainly you don't add all the time that you do with image guidance. In Ron Affelbaum's series, which we went back and looked at, actually it wasn't as good as what's reported in the literature. We went back and looked at 30 patients. We placed 53 screws, and all of these patients had postoperative CT to make sure that we had been accurate in our screw placement. What we found that we could really only reliably depend on the stereotactic guidance in 21 out of 30 patients at the time of surgery. In other words, things didn't make sense when we tried to merge our intraoperative findings with our preoperative CT scanning. In that case, you have to go back to your fluoro. And then in those 21 patients that we thought we had good information, well, we found that 13 out of 21 had excellent placement, but we were off in about 8 of the patients. So again, what do you do if you have a situation in this type of construct where you can't place one transarticular screw? It's probably almost as good to just place one transarticular screw on the side that you can get in and then use your cable grafting. In many studies, biomechanical studies, this fixation is almost as stable as 2 screws. Now, there's a new technique which has come available, and I call it the Harms technique, though there's a lot of debate whether he first described it and so forth. Let's just call this a C1 pedicle and C2 pedicle, or C1 lateral mass and C2 pedicle construct. And what we describe here is a construct that is very useful in somebody who has anomalous anatomy. What we do is we place a C1 lateral mass screw right under the junction of the C1 arch, and then a C2 pedicle screw, and simply link these together with a rod. This is a technique that has become available now because we have these screw rod systems that are useful in the posterior cervical spine. How do we do the C1 lateral mass screws? Well, we use a straight or slightly convergent trajectory, okay, in the axial plane, and then we angle in the sagittal plane up to the anterior arch of C1, as you can see here. I place these with direct visualization of the lateral mass. In other words, we take care of the venous plexus that's around C2 and actually skeletonize the C2 nerve root and pull it down. Now you would say, well, doesn't that cause a lot of suboccipital neuralgia? Well, in the bigger series that have been noted to date, no, it hasn't caused suboccipital neuralgia, and I have not noticed it in my patients, but it's certainly a concern. So that's something you have to consider. The other thing is that venous plexus can bleed quite vigorously, so you have to be ready with hemostasis there. I use powdered gel foam and pack the area off, and that works quite nicely. Then for C2, what we do is something here. Now, I try my entry points sort of on the upper medial border of the pars, and a variety of angles have been suggested. This is actually an anatomic study that was published in Spine recently, suggesting that you should angle about 35 degrees in medially and up towards the base of the odontoid here, as you see, about 35 degrees again. What you aim for is the base of the odontoid, as you can see right here, in your lateral projection on your fluoro. What I usually do is say, oh, okay, it's about 20 to 30 degrees up. We'll aim for that point, and we'll angle about 30 degrees medially. And that's how we place our C2 pedicles. The thing that's been published in the literature is Jürgen Harms' series, where there was limited follow-up, and really only 18 patients out of 37 had 1 year follow-up. So you're kind of uncertain how the patients did and whether it was really a rigid fixation. However, he noted no hardware-related complications, and certainly everybody he was able to follow was fused, although he quoted a 37 out of 37% fusion rate. I think really you can only look at those 18 patients that he was able to follow for a year. The other thing you can do with this technique is, as you can see here, here's somebody who had a very unusual odontoid fracture, a young guy. This is very high. And what we were able to do is we could not reduce him intraoperatively just by positioning. However, when we put these screws in, we were able to pull the screws back to the rod, okay, and get a better, what I think is a better anatomic reduction right here. It's not perfect. We could have done a transoral, but I certainly didn't want to subject this kid to this. And I think this is a better technique for getting some reduction at C1, C2. In terms of biomechanics, how useful is it? Well, Dan Kim published a nice biomechanics series, and what he found was that posterior transarticular screws and the lateral mass pedicle screws had the same stabilization, okay? Same stabilization in an odontoidectomy model. So this construct clearly is as stable as transarticular screws. In addition, you can also add this to an occipital cervical fusion, and if somebody, particularly an elderly patient, has weak bone or non-existent bone at C1, you always have your occiput as a bailout point. As you can see, we had to use in this gentleman who had, frankly, erosion of his C1 lateral mass. So in summary, we have a variety of viable alternatives to technique and cable grafting alone when it comes to posterior C1-2 techniques. We have to understand each patient's individual anatomy by careful preoperative planning, but we still, no matter how fancy we get with our techniques, and no matter how fancy we get with our instrumentation, we still need a good fusion, and we still need to pay attention to how we get that fusion. Thanks for your attention.
So we've seen two excellent talks, I believe. One big picture presentation by Randy that raises the perspective of non-operative management in patients who present with an acute fracture, and then a surgical perspective.